Y, just because we can't pronounce her name. Every time I have to ask her again how to pronounce it. I'll have her pronounce it for you when she starts talking. She shows so much compassion and understanding to each and every patient that she works with. I'm just so in awe of the way that she deals with her patients. So, of course, I asked her to come here, and she said she would. So I'm going to turn it over to you, Dr. Y.
Thank you. Thanks so much. Thank you. Awesome. Thank you very much. Just my last name pronounces as Yessengaliyeva, so that's why you know why I'm going by Y. You know why. Yeah, and just Elmira for short right now. That's okay too. And I graduated from Medical University in Kazakhstan, which is where I'm from. I did go to the residency program here at Western Michigan. At first, like, okay, at first I did go, entered to Kalamazoo.
Down a little bit.
Okay, like here.
Just click it there.
Okay.
Okay, then forget about it.
Perfect. Thank you. So entered the Kalamazoo Center for Medical Studies, KCMS, and then graduated at Western Michigan University, right, like the medical school. So,
Almaty?
Almaty, yes, yep, Almaty. Wow, people know, that's nice. I am an assistant professor at Western Michigan University. I did go to Stanford for geriatric psychiatry fellowship. So this is where I work. We are based at Borgess, but we work with WMed, so for both hospitals. So. I'm a geriatric psychiatrist, and I also do electroconvulsive treatment, so that's what we're gonna a little bit talk about today too, just destigmatizing some things. So I didn't know, like Lori, when she asked me to present, she said it's gonna be a small group in the church and everything. That's very nice, small groups here, so I apologize. I try to think like what I need to present and how. I have only 5 or like 6 slides, but I want to more talk and more leave the questions, like basically time for questions and answers. So, because I think like there will be a lot of probably more of that, so we can more target the need of people, you know. So and this is my first talk, probably more in the community based, you know, because it's more students and residents and everything. So I don't know what people would be interested in, and so that will help me in the future as well. So for the feedback. So nice, great speakers before. So what do we know about depression, right? Depression hurts. It is a real disease. Right, so, and I think it's like it was very stigmatized before, right? It was a taboo in so many years ago to talk about it, right? Like, oh, just snap out of it, get over it, and that was part how people were like, why don't you just go outside and walk and everything? You'll be fine, right? This is how people are like used to think about it in the past, right? And the other thing is, it is a real disease, right? So some people do get diabetes, you know, you get treated, right? Some people get high blood pressure, you do get treated with medications, right? Depression is one of the same organic diseases. And just for the future, you know, like I think the future research will show that there's a depression and there is a depression, right? Every person is very unique. We have so many chromosomes and that's, you know, childhood experiences and everything makes our human, like as a human being, a very unique person, right? So how do we suffer? How are we resilient for things that happen to us, right? Like, so every person has their strength and their weaknesses, right? And it's everybody is very unique. So, and this is, but everybody suffers the same, right? It does bring the suffering. The depression does hurt, so it does need to be treated. So that's what we're going to talk about today, about the treatment of depression. And why I was talking about that depression is different from depression, right? I think it's a future, probably research, and it's going to be happening in the future, because I had, as a geriatric psychiatrist, I had people who come to me in their like 70s, right, or 80s, and they come in and they say, I don't know why I feel this way. I feel so ashamed. I have a wonderful life. I have a great significant other, very supportive. I have wonderful children. They're all overachievers. I have like everything. I have a house. I have everything. I don't know why I feel this way. Right? So, and they don't know, they don't have any childhood, like negative childhood experiences, they don't know. So, but this does exist and it hurts. So, and that's where revealing that, and talking more about it, that it does happen, and it's nothing to be ashamed of. It's nothing that people did right or wrong or something, just, somebody to blame for. It just does happen. And it's probably the future research will show like more about, just not only just, oh, this is a chemical in your brain, this is serotonin that's like needs to be taken care of. No, I do truly believe that there's many more factors inside of our brain that are like, that we can take care of and fix, and I think it's, as I said, is a future research. But we're going to talk a little bit more about today, let me see, I can't see. Down, okay, thank you. So, treatments of depression, right? There's different types of treatments, and the first, a therapy, right? It's a talk therapy, how people know it, right? So there's different types of therapy, and when you go to a therapist or like a psychologist, they will usually pick what would be the best treatment option for you, like what type of treatment. So there's you probably know or familiar with a cognitive behavioral therapy. So it's a very good treatment for depression, for anxiety. Sometimes does work for like majority of people, but some people would not be able to go through that too, So this is where the therapist will pick a unique therapy for you, for the person, right? So that's going to be, there's different types of therapies, dialectical behavioral therapy. So it works more a little bit with suicidality and mindfulness, right? So then the others, like interpersonal therapy, it's very finite. It has a very strict criteria, kind of like, and timing too. So, but there a lot, and the therapist is somebody who is going to help the person to go through that and like treat, and I think like what we were talking about, that ACE, right, like the previous talker, I think the best part would be go through the therapy first, This is practical talk about the therapist, right? You can self-refer. What I do talk to my patients about, like on the back of your insurance card, there's a number for mental health, right, coverage. So call that number and ask for the providers, therapists who are covering, like who are support in your area, who they cover. Okay, they can give you a list of providers, and as I think Rohan also said that, the therapist is a unique person who, like, you have to click, right? Not all the people click. Like, that's a usual, right? That's a normal kind of, like, we do exist, everything, but not a lot of people, like not everybody clicks with each other, which is normal, right? We can coexist, we can do, like, kind of work together, but with a therapist, it is a person who you have to trust. So when you go to a therapist, give it 3 times, okay? If by 3rd time you can say, like, I don't feel like I'm trusting, I cannot open up, it could be just, there's something not working. And the therapist usually, they do know, because they know about the click, right? They know what needs to help. And you can just basically go to a next one. It might be several therapists like you go through until the person you will be able to connect with, who will be able to help. So then let's talk about medications, right? It's the next part of usually you have to go to a psychiatrist. So for the therapy, you can self-refer, you can go and ask for the therapist and just basically to walk in. I wouldn't say walk in, but you have to call probably now. But so psychiatry is a little bit different, right? You have to be referred. There are not a lot of psychiatrists, so it's the wait is unfortunately a very long time. When you notice somebody who is not doing well, who is isolative, who is talking about suicide, right? Usually it is a criteria for admission to a psychiatric unit. Usually from the psychiatric unit, it is easier to be referred to a psychiatrist. It probably will take maybe 1 to 2 months, but still it is a long time, a long wait, unfortunately. So, but the psychiatrist will be able to provide you information about the medication treatment with the of the depression. They'll see how severe the depression is, what causes that, right? So, and pick the correct treatment for you. Usually I do go by side effect profile, right? Not a lot of, there's different types of medications, right? Let's talk about for example, selective serotonin reuptake inhibitors. Those are medications, probably you've probably heard of those, Prozac, Zoloft, Celexa, Lexapro. So those are, they have a very low side effect profile. They're very easily tolerated. Unfortunately, they're not working just like that, right? I wish we could do that, right? It would be probably the best ever treatment. But it takes up to 2 weeks to show some effect, and 4 to 6 weeks to build up the full effect of the medication. So that's why I tell my patients, you have to just hang on a little bit, that's just a little bit of patience. And I know it's when the person is in the darkness, it's very hard to do. And would be nice to have something different. There's another type of medications. So selective norepinephrine serotonin reuptake inhibitors, those I don't want to do a lot of the chemicals part, but they work in 2 chemicals, right, in the brain. So usually when the people are depressed, they found out that serotonin is a little bit decreased in a certain type, part of the brain, and that's what the medications are helping to increase that. So the norepinephrine and serotonin reuptake, you're probably familiar with those Effexor, venlafaxine, Celexa, not Celexa, the Cymbalta, or Pristiq. Those medications are working on 2 chemicals in the brain, helping to normalize that. Similar things, it's since it works on norepinephrine, 1 more chemical in the brain, hence the side effect profile. So you have to watch about side effects of that. And the psychiatrist usually does provide you information on that, what to look for, and basically and what to tell. The biggest side effect, I think that almost everywhere, the black box warning of those medications is increased suicidality, right? So that's what people are more worried about, right? So, and especially in kids, right? It's more in the children. I think there is a talk right now to remove that black box warning, because what they found out, the untreated depression is more it causes more suicidality rather than treated depression and a side effect of medications. So what they found out also that it's untreated depression is more yes, causes more mortality rather than like if you start treating it, people have sometimes more attempts but not completed suicides. So with the depression, it's a lot of completion, like suicide completion, as you probably know too. So then there's other like tricyclic antidepressants. Those are like amitriptyline, imipramine. So those are medications that were a little bit older than SSRIs. That's the first ones. They have a little bit different side effect profile. They work, but usually not as easy tolerated as the other ones, but that do have a little bit actually higher rate of success in treating depression too. But they do have, of course, different side effect profile. That's why the psychiatrist will have to pick if that's a correct medication for the person. Okay, so then there's even the other older type of medications, monoamine oxidase inhibitors. So those are type of medications that you have to have a certain diet, to be on certain diet, because they can cause, like if, for example, you cannot eat like a lot of spinach, you cannot drink like red wine or aged cheese or anything. So usually it's provided, you know. But it can cause, like if you do not take precautions with the diet, it can cause what they call it a hypertensive crisis, right? Like the blood pressure rises up really high to the point people have to go to emergency room, and it is a very emergent situation. So that's why when psychiatrist picks the medication right for the person, right? So this is where it's like it comes from, right? They have to see how you would be able to adhere to that, or, you know, are you able to go into the diet, right? Like, or like, because I've had people who did really well, right? Like sometimes SSRI works, but sometimes they said, you know, like I've tried everything and I'm fine with keeping myself like off, like I don't need cheese, I don't need wine, but I need to feel better, right? So, and this is where it's like you have to take into account. So, and there are other medications that are from different types, like so they're like, for example, Wellbutrin or bupropion. This is like a lot of people probably heard of that. Interestingly, it's sold for smoking cessation, like Zyban, you probably heard that. It's a pretty high dose too, but when the psychiatrist orders it for the depression, it has to be like titrated, you know, like, so it has to be started with a small dosages. But for different reasons, it doesn't need to be like Zyban. I think it's a pretty big dose too, so. But works well, and the same thing, you know, like the side effect profile. So that's where like it gives a little bit more energy, I think, to people. So it works with the focus. So like you have to see what the person needs are at this moment. So when you pick that, trazodone is a little bit mirtazapine, Remeron, and trazodone is a little bit different. Like they don't fit into the criteria of like this type of medication. So they cause a little bit like that's where the side effect profile could be plausible, right? Like both of those do cause a little bit somnolence. So when people don't sleep well, right? So those medications help with the sleep. Sometimes some of them, like I think Remeron can increase the appetite too. So some people will not pick that as their choice, but like, so usually I do talk with my patients, you know, like, can we get the, you know, like, okay, this is what we want, right, to accomplish. So how important is this for you? So, and this is where it's like, but something needs to be done, right? Depression needs to be treated. So then there's neurostimulation treatments. So that's part of that. The newest type of treatment is transcranial magnetic stimulation. And we'll, let's see. So that's basically, it's a very, it's a magnetic field that's or built around the area, like a certain area in the brain, and shown some good results with the depression. Not as good as ECT though, like the electrical, but we'll talk more about it. So the pros are, it is non-invasive treatment. You go to their office and it's 20 minutes, but the cons are, I think, you have to go there for every day for 3 to 6 weeks to the office. Yep, there are several offices in the community who do have this treatment. Unfortunately, not all of the insurances cover that. So majority of the time it comes out as an out-of-pocket expense, which can cost, like for the full course, it could be like $10,000 or something. So yes, so that's a pretty, like it's a big expense. So, but you know, non-invasive, as some people do invest into that, they say like, I need to feel better, right? So, next one is my favorite, is ECT. So that's why I just want to tell you a story about one of my patients who, I used to work as an ultrasound tech and did my like exams during that, and you know, so I volunteered in the office, psychiatrist office, and one time there was a woman who came in and she said, you know, I've had a year and a half, I've been feeling so bad. I cannot, like, I have small kids, and I feel so irritable sometimes to the point where I feel like taking them out, like in the highway driving, taking them out on the highway, because I cannot stand there screaming. I can't, and it's horrible to be a mom in this case, and I cannot stand. But at the same time, she said, this was when I rotated in that office. That was her 6th or 7th psychiatrist she went to. And it's in this year and a half, and she didn't like others, right, other psychiatrists, and I think she moved even from the state, different states. So she was labeled, right, like kind of difficult patient, of course, right, like she doesn't like. So she was reading all of the side effects too, you know, like kind of like, you know, go in and Google and like reading, and she would develop all the side effect like profile from all the medications she was on, like every single one, you know. So psychiatrists don't like that, you know, like it's like when the patient comes in, it's like what now, what do I do? So, and you know, and I think that's where the psychiatrist, you know, like sometimes it's hard, but you have to understand that the patient is suffering, right? For a year and a half, it is a miserable life. So why I came across, like, why did I start to talk about ECT? A year and a half later, I was in a residency program, and actually I saw this woman a year and a half later. She was hospitalized in our facility at Borgess, and she saw actually a different psychiatrist at that time already, and she was referred to ECT for electroconvulsive therapy by that psychiatrist. So, and I happened to be there, and I happened to be following that psychiatrist who did electroconvulsive treatment. After the first treatment, this woman was walking in the hallway, almost running and laughing. Wow. That's where I believe that I like that, and I need to learn this, how to do this, and you know, like this is where, this is the treatment that does help. A little bit sometimes faster than medications when, you know, like, so it's usually, you have to be eligible for ECT, you have to fail two medications, right, 2 antidepressants. But because it is really involved treatment, and it does affect the whole body, because you have to go through general anesthesia 3 times a week. So it's not for everybody, right? And you have to make sure that the medically people are will be able to do that, you know, but it does help, and it helps in like treatment-resistant cases. Interestingly, historically, that even in 16th century, Paracelsus was caused like curing the lunacy by giving a camphor, like orally. So like people were swallowing it and having a seizure. Then I think in the beginning of 20th century, there was a wrongful assumption, but people thought like that people with epilepsy don't have depression. So it proved to be wrong, but at that time it kind of caused people to see like, oh, let's try to cause this, like the seizure right now. And of course there were a lot of regulations at that time, right? So they, like FDA and everything else. So they tried to do chemical, they gave camphor to people and sometimes like injection. So problematic part was that you didn't know when the seizure is going to start. Seizure could be like in 5 minutes or an hour, right? And it was not regulated and everything. So, but then I think Serletti and Bini, they found out that apparently the electricity can cause the seizure as well if you put it through the brain. It was in the 1930s. And so in 1939, there was a first human subject in the United States. So in 1951, but as you probably know, there's a lot of stigma about it, right? And I think a lot of people know about electroconvulsive treatment from the like One Flew Over Cuckoo's Nest, right? Yeah, that's the biggest, like kind of like that brought the big stigma about it. But it was actually pretty scary treatment, right? Because there were no medications, the people were awake and people were going through the seizure, right? In 1951, there was a muscle relaxant that was introduced. And muscle relaxant is the medication that you give like through the IV, and it relaxes every single muscle in the body. So the people like don't go through the seizure itself. Right, so and then but it does cause that like the diaphragm is not like making the breathing movements anymore, right? So that would be probably pretty traumatic experience, right? I cannot breathe right now, so but I cannot save in that. So that's why it's done under general anesthesia. So the anesthetic are given, so people are falling asleep before the muscle relaxant is given. So, and then it's usually the small, like right now it's not the sinus wave, so basically you cannot go into that, like the outlet and just cause the seizure. Right now there's a lot more studies are done. The type of electricity right now, what it's called the pulse wave. So it's very short kind of bursts of pulse like that do cause the seizure. And it's a very short, less than 2 minutes, very controlled. People are like basically sleeping. We're measuring their blood pressure, their heart rate. The nurse anesthetist is breathing for them. Usually, and the nurse is there to help everything else too. So people wake up in 5 minutes. They're a little bit disoriented, but then it usually goes to normal once they are going in the room, and probably within an hour, right? Lori would say that they're coming back to normal, and then they're sent back to their room or outside. They actually leave the facility. They cannot drive, and usually sometimes it can cause a little bit of memory problems, so we usually tell people do not make big financial decisions or anything like during the course. So, but I did want to show you the video that it was done actually through, I think in Australia. So that's why it's like it's a short one, I think 8 minutes or so. And then it does talk about a little bit about the ECT in there, so we'll see.
Just a minute.
Sure. But talking like, well, we have this, we can talk about usually the response rate, right? The response rate for medications is like, for example, like probably around 40% chance of getting better. Placebo is 30%. So it's a little bit over placebo. So when you combine medications and psychotherapy, the percent does rise a little bit higher. Okay, transcranial magnetic stimulation shows a little bit better response, but not like probably above, a little bit above the both medications and psychotherapy. But ECT by different studies and different resources, usually up to 80 to 86% of chance of getting better. So this is why it's still considered a gold standard treatment for depression. So.
How long is the treatment and how much is it?
Yeah, so all of the insurances cover it, even Medicaid, Medicare, so like everything covered. I do not know how much out of pocket would be, you know, like for people. Treatment usually, there's acute treatment and there's, they call it maintenance treatment. So acute treatment is 6 to 12 treatments and they're done 3 times a week. In the United States, most 3 times a week. In Europe, I think it's done 2 times a week, but we want it done faster and more, right? We want it done faster, so. So 3 times a week, so you're looking at 2 to 4 weeks. Very rarely when people have the response after the first time. It's probably less than a quarter of people. By the 3rd treatment, people start feeling.
So have you had electroconvulsive therapy?
No.
No.
So electro-convulsive therapy? Nah, sorry. Yes, oh yes, yes. Well used in the old days.
Is that like the electric chair you're talking about?
ECT has actually given me my life back.
I was frightened, really frightened the first time, but you know, as I come along and I see the rewards of ECTs, you know, I've known now there's nothing to be frightened of at all.
Yeah, it saved my life and it saved my family.
I was suicidal, extremely suicidal, believing that there's no way out.
He was in his bedroom, not coming out, couldn't come outside, couldn't do anything.
You know, I was suicidal and I even attempted my own life. I had an attempt and thankfully I failed. But I was absolutely, every minute of every day, was trying to think up a way to take my own life.
I have a young child, so I have a 3.5-year-old. So my suicidal ideation wasn't so much that I was going to act on it, but that it was just preventing me from getting any joy. I went and saw my doctor and told him all of that. He said, you know, I think we should start to look at this for you now because it has been, he has tried me on lots of different treatments over the years.
Sometimes people are in a position where they're unable to speak, unable to eat, or feel so absolutely dreadful that they just want to die all the time. And within a week, they might be sitting up, chatting, looking relaxed.
And this way they're able to go home to their loved ones and be able to lead a good quality of life rather than being on the wards.
Talking about major transformations, that is the norm. ECT, it's like a magic bullet, and you do see, sometimes it's like somebody has waved a magic wand.
Some people take longer, multi-weekends, and some people, you know, maybe don't get the same response that they expected. But in many cases, a majority of people that actually coming through ECT treatment, they had a very big difference.
As a husband and a cure, you know, the first time she had the treatment, it got to the point where I didn't know what to do anymore, and nothing was working. I just said,
let's do it. Can we do it now? And he said, no, we have to do some tests first.
So prior to meeting my doctor, I had probably pretty similar ideas, than to people in the mainstream.
The images I have is somebody convulsing in the bed without anesthetic and reducible.
All I think about is people getting their heads cut open. Lobotomies and things like that. That's kind of the only thing I've been like.
Yeah, one who flew over the cuckoo's nest. Oh, yeah, okay, yeah, I know what shock therapy is now. Yeah, thank you.
There's a lot of misinformation on YouTube, when people look at TV shows, videos, and ECT has really come a long way, compared to how it was demonstrated years ago, and in terms of treatment, it's really advanced.
They feel that there's a lot of stigma with ECT.
So we educate them and make them feel a lot more comfortable about the procedure.
Yeah, I think the biggest misconception is that they're going to be anxious, or it's going to be painful, that there's going to be shouting, that they're going to be held down.
And it's not none of those things. None of those things that I thought it was.
The team where I went was so great. You go in, you walk into the suite and you sit down and lie down on the bed, and my doctor was great and asked me what music I'd like to listen to, so tried to make everything really comfortable. They were cracking jokes. It just felt very routine and comfortable for them, and that helped set me at ease. And then, the basic stuff with a general anaesthetic, can you count back from 5 for me? Before you know it, you're waking up again in another room.
Come the 3rd, 4th and 5th ECT, bang, 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 all the lights start going on, and I can feel and I can, taste, and a life, life can be lived. And then it took through to the 10th time, and just the one day I felt that, I wanted to go watch telly. Now you might think that's a nothing thing. A lot of people watching telly, and I wouldn't want to join them.
I know that when I finally came out for my 10th ECT, when I started to see the light, I came out and the nurses were almost in tears because they saw me looking them in the eye for the first time and I had a smile on my face.
The last year I've been working here, I've only seen one person who didn't recover as well as we would hoped. So it's common that you'll see a big difference in terms of your mental health.
What ECT is quite good at inducing is a remission, so that the symptoms of the depression usually, but maybe other psychiatric symptoms, become so diminished that the person's practically without symptoms. So their mood's kind of normal, their eating, sleeping, all of that's normalized.
For the most part, the patients that I have looked after, they're concerned about memory. So during the ECT, they may notice those side effects, but usually that comes good, and the benefits certainly outweigh any side effects.
To know that there's an option out there that isn't about readjusting to a new kind of drug with lots of side effects, I'd say it's worth trying. It's when you're really low and really depressed, there really is nothing to lose.
If I hadn't had ECT, I wouldn't be able to tell you now that it was worth it, because I'd have been dead.
And I absolutely back that up, 100%. And our children would also, because they've got their dad back. But I felt so good. Such a difference, I was a different person again. I'm still on meds, but no, I feel on top of the world, actually.
The number one key benefit, for me as a nurse, to see people get well quickly, to have wellness again, to get back to quality of life. That's been the most satisfying thing for me. But then putting myself in their shoes, can you imagine how they're feeling? To be able to go from not working, not functioning as a family member, not functioning in society, and feeling like they're having a meaningful life, to back to hobbies, back to life, back to being able to provide for the family. So those sort of benefits are immeasurable.
Having ACTs and a course of ACTs gives me a life. whereas before I haven't got a life. I don't want to be on this planet. You know, that's how scary, how deep I go into depression. You know, and what ECTs brings me up into living life again. So I'm so grateful for that.
Have to turn that on. I just wanted you to see the video. You know, this is just explains ECT and kind of like just who familiar with Scientology and have watched their videos? Okay. So just recently, one of the family members called me frantically and said, "Oh my gosh, yesterday I watched this video. This is horrible. Can you, like, if it would be that bad, it probably would be closed, correct?" I'm like, yes, correct. I'm still, I have to watch the video he's talking about. I think there's like a 60 minutes, some kind of presentation. So at least I'll be familiar with, but ECT does not cause personality changes. It does not wipe out completely the memory. It does not cause the brain damage. And I think there's I read the article recently in a case report. There was a woman who was in her 90s when she passed away. She had diagnosis of schizophrenia, and in her lifetime she went through over 1,000 ECT treatments, which is like a humongous amount. So, but when they did an autopsy, they did not find any brain damage, like at all. And she actually, I mean, like if she was in her 90s, so she went through probably a pretty invasive treatments in the past, right? Before the, like, you know, the other stuff was invented. So, but they didn't find any microscopic, any problems like with like any damage. So, but now I think I'm open to questions. So, yes, probably should we? Sorry, wait. I think they're going to give you a microphone.
Yeah. He does it better than I do.
You have the question? She had 1,000 treatments. What's the norm, though? I mean, for treatment, and how long does it tend to last once you've had your series?
Yes.
Yeah.
So as we were talking about, series is 6 to 12 treatments. That's a standard treatment number that usually we do. By 12 treatment, majority of the people do like go into the remission.
How long does that tend to last? For good?
That's a different question too. So this is not the cure, unfortunately. So, and usually I've had people who went through it once and they're doing actually fine, and they're like, I've seen them work and everything, and it was like 10 years ago, and they haven't need any ECT anymore. I had people who needed the ECT treatment like every 5 years, because there's like almost like with the depression going like every 5 years. And I have people who are on maintenance treatment who are receiving the ECT every 3 to 4 weeks for like indefinite period of time. So when I was in training, Dr. Westerman, my supervisor, so we had the person who went through ECTs, and I think it was her 100-something time, I think so. But her story is interesting too. She had the severe bipolar disorder, and at the very beginning, her family was so against the ECT treatment that was proposed, but she was in and out of the hospital. There is no quality of life. She was on that list of medications, right? So this is, it was incredibly, but the family were really against ECT. So I think one of the psychiatrists went to through the court and kind of did that against the patient's will. After that, the family insisted on ECT every 4 weeks. Okay, because they were able to decrease the number of medications. She was able to be taken care of. She lived in kind of like had pretty good quality of life. So that's where, like, so at this point, like, you never know. So, and you cannot predict, or you cannot tell for sure how many, or like when it's going to strike again. So.
Question. What I was wondering, could you talk about Prozac some and the side effects of it and how it affects people?
Yes, so Prozac is one of the serotonin reuptake inhibitors, selective serotonin. So it's the medication that has, it's longer acting. So it means that there's a Prozac weekly that can be given like once a week, which is nice when people are like, you know, you don't have to take it once a day. So all the, like that class of medications, what they do, they talk about is GI upset, right? There's a lot of, sometimes people feel nauseous, sometimes can have like vomiting or anything. So, but that's because the serotonin, that the medication they work on, is not also in your brain, but in your guts too. So once it's activated, that's where you can feel that. Usually finite, like after 7 days, should go away, okay? But other than that, of course, black box warning for suicidality. It is approved for kids as well, but majority of my people tolerated it well. So SSRIs don't have like big side effect profile that is not, you know, like, so usually tolerate it well. So, is there anything specific you wanted to like talk about, like about that side effect, or?
There's times where I have stomach aches and stuff, and I'm sitting on the toilet for a while.
Oh, okay.
So I don't know if that has anything
To do with it. So usually it's a very, like at the very beginning, that could be, but I cannot 100% tell you that it's not Prozac, right? Like, for example. So that this is where between you and your psychiatrist, you can, what we've done so far with my patients, right? Like, and I don't know if your psychiatrist will be able to do that, or with one, sometimes elimination, right? You have to, like, if you take away the medication, right, is that going to continue, right? Are your symptoms so severe that you want to risk be taken off Prozac and possibly go into deeper depression, right? So this is where it's like, it's kind of hit or miss, but 100% I don't think I'll be able even to tell you that. It might be from Prozac, but usually it's a very, like at the very beginning happens, but then the body tolerates it well. But that's the biggest side effect, which is, I think, which is a good thing. It doesn't affect a lot of, like, usually the SSRIs are weight neutral. I had rare patients who did started gaining weight on those, but it happens very rarely, but people are unique, right? So this is where it's...
We have a question over here.
Yeah, absolutely.
You know the drug, the bupropion?
Bupropion, yes.
And
yep.
it's been used for smoking cessation.
Yes.
And I wondered, what parts of the brain does that work on? Does that work on the serotonin? Does that work?
Usually it's norepinephrine, dopamine reuptake inhibitor. So those, it works on two other receptor, like, or I mean the chemicals.
What was the dopamine and what was the other one?
Norepinephrine and dopamine.
Okay, thanks.
What about Lexapro and Wellbutrin?
Bupropion, that's a Wellbutrin. So, yep, so it's a medication, like, so let's talk about Wellbutrin. Wellbutrin is Zyban for smoking cessation, right? Or bupropion or Wellbutrin for depression. Wellbutrin does not sometimes treat the anxiety as well as, for example, Lexapro, but it has a little bit more activating effect. So, and I think it does increase focus too. So sometimes in some cases it's used for ADHD as well. So to increase the focus. So that's where when you have like low energy and everything, it kind of would be medication for that. Lexapro, it's same as similar to Prozac. So it has a little bit, Lexapro I like because it does have less drug-to-drug interactions, so it basically does not affect other drugs that you're taking, for example, so that's where, but same thing is easily tolerated and can cause GI upset sometimes, but in some people it doesn't, so.
All right, we have a question here, and then we'll get...
What about Nucor? We've done that as well, where you go in and they plug you on, all different parts of the brain, and then through your brain, you watch a video, and if you're not concentrating, the video will stop, and it's like retraining your brain. It is amazing. That.
I think it's part of the biofeedback therapy.
Yep.
So that's the possibility too. It's a very good therapy for depression, or sometimes, like PTSD or some, like that, when you have that response, like when, like the stressor response, like you're kind of like getting so anxious and, like sweat and everything. So it trains your body how to react in a different ways.
It was like they did a beginning, what your brain looked like, and then did 3 months of treatment, and the brain shifted, like all the different colors and all the ADHDs and everything that kind of went on. I ended up going through Mary Free Bed and did the same thing for a brain injury. I had a brain injury, and that's how that was like 10 years ago where biofeedback wasn't even, but I also have a son that just went through that last summer through Nucor, and it was amazing. And it was covered by insurance.
Oh, that's awesome.
Yeah, and it doesn't hurt. And he just was able to pick his own videos or his own movies, and he brought them, and as soon as he wasn't concentrating, it stops. So then they have to retrain, and I don't know, it's just something, out there.
Something different, right? Like something, if like people are like, decide the way, not with the medications, like I always like, if it helps. As I said, depression is different, right? So, or like something does not work for another person, might work for another person, right? So.
Okay. You said that selective serotonin reuptakes are only about 40% effective. How much of that is related to the dose?
You have to be on a therapeutic dose too. I think it's like usually when they do studies, they don't pick the highest dosages, right? So, but it is usually a therapeutic dose. So, to tell you the truth, I do not know how that would be related to the dose. I think it probably would be like not dose-related response, unless you're on a subtherapeutic dose. Like if the person, like for example, in the Prozac, like 5 milligrams, which is almost nothing, right? Like, or it's like subtherapeutic, it's not going to give the effect of anything, right? But usually what they did look at, they didn't look at the dosages, right? Like of the therapeutic effect, but just the dose that usually would, like majority of the people would be affected.
So there's no data to show that higher levels would necessarily have a higher efficacy?
No, I don't think so.
So for the Lexapro or Prozac, what would you consider the higher doses for those?
So usually Lexapro has I think it's a FDA approved, the highest dose maximal is 20 milligrams.
Oh, 20 is the highest?
I think it is 20. And then the Celexa has like, I think it's 40 milligrams, but it could go up to 80, but not in the older adults.
Oh, okay. Thank you.
Thank you.
We have time for about one, maybe two more questions before lunch. You have a question over here? With ETC having an 80% outcome, is it related to the patients doing a follow-up with psychotherapy or medications?
Yes, they must. They have to be on medications. Yep.
One more. Okay.
What is the long-term implications of being on like Prozac and those type of things? And I've also have friends that have been on it and then says it doesn't work anymore. So it's almost like they get immune. I don't know if it's a myth or what, but anyway, what's your thoughts on that?
It's not a myth. You know, like there's such a thing like what they call it, the poop out effect. Right, so it has been working, but then it stopped working for some time. So usually in this case, if it has been helpful, I would consider another SSRI, you know, like to go to let that like it wash out of the body, and then maybe reintroduce it in a couple of years again, knowing that it does help. But it does, and this is where its genetics comes in, right, in the play, where why some people are on the same medication for years and years, and it works. But then some people do have that, you know, like kind of build up in the fat, like kind of tolerance, and then they don't respond anymore. So this is the, like a big question, and I think it's like so, like all in the future responses. And the other part is you cannot, like tell for sure like which medications will help, right? So, but the unfortunately antidepressants are not the cure too, right? So it's not like, almost similar to like high blood pressure medications, right? Without those, it's gonna be like taken off, like the effect and the high blood pressure rises. Same thing with the antidepressant. You have to take it consistently in order for that to help. So, and when people are asking to go off the medication, right, that's where you have to weigh in, like, sometimes, you know, like that's what could happen. But it might, like, the depression might come back, but it might not come back, right? So, and I don't have a looking glass to say that 100%, right? So you kind of have to make chances, like take chances. So that's why I think majority of the people are just deciding to just stay on the medication for like indefinite period of time.
All right, good questions, everybody, and thank you so much. Let's give Dr. Y a hand. Thank you so much for speaking and sharing all your wisdom with us.